Good afternoon, all. We are live and we will be starting in a moment. Our presenter, Dr. Ombeva, is already online, and we are grateful that you have taken time to log in from wherever you are. We would like you to input where you are logged in from. I'm the co-host today. I'm Dr. Joy Mogambi, standing in for Dr. Kigondo, who's in Nyeri for the COVAX conference. He'll also be joining us shortly.
Yeah, Joy, I'm around.
Yes, welcome. Thank you very much. So feel free, feel welcome. As housekeeping, you've got your panel on the other end, which has a Q&A section. Do feel free to log in there, ask questions if you have any questions as our panel of speakers goes ahead. If you have anything to drop into the chat, maybe a compliment, a comment, you can drop it in on the chat box on your end, and we will respond to that as we go ahead with today's presentation. So over to you, Dr. Kigondo. You can welcome our speaker today as we go ahead.
Thank you very much. Welcome, everyone, to this very timely KMA COVID-19 series. Today, we are privileged to have Dr. Ombeva Malande. Ombeva Malande is a vaccinologist and a senior consultant in pediatric and infectious diseases. He has a PhD in vaccinology research focused on vaccine hesitancy in Africa. He is a certified fellow of the College of Pediatricians of South Africa, infectious diseases subspecialty. He holds a subspecialty master's with distinction in pediatrics, infectious diseases, and vaccinology from the University of Cape Town, South Africa. He has an M.Med degree in pediatrics and childhood from the Makerere University and an MBCHB degree from the University or Moi University. He is a convener of two widely acclaimed courses currently offered by ECAVI Vaccines Academy, and he's also a weekly columnist and advocate of child health with the Eve magazine on Sunday Standard of Standard Media Group. Without much ado, I want to welcome Dr. Ombeva to take us through COVID vaccination. Welcome, Dr.
Thank you so much. I'll be hiding my face briefly so that I can go into the slides. So thank you so much, Doc, for the very warm introduction. As you said, I'm a vaccinologist, and vaccines is something I find a lot of passion in doing, just for the purposes of making sure that we increase the number of people who get vaccines and make sure that we reduce the number of children and adults who die because of vaccine preventable illnesses. For that reason, I'm very actively involved at the East Africa Center for Vaccines and Immunization. That's the one we call EFFICACY, where we advocate, we teach, we do research, and we support health systems across Eastern Africa, in the 11 East Africa and Horn of Africa countries, is to make sure that governments and countries provide vaccines and develop demand. So one of the things we do is we try to encourage communities and participate in making sure that people are able to demand and ask for more vaccines. I'm also a research associate with the Sefako Mahato University in South Africa, Pretoria, where we collaborate in a lot of research work in areas of vaccinology and child health especially infectious diseases. I should add that in terms of conflict of interest, I'm doing this presentation on behalf of the Kenya Medical Association, for which I'm a member. And so I have no conflicts of interest to declare. I'm a public servant. I work for the government. I'm a government employee teaching at a public university. It's important to mention that COVID-19 has been with us for just around 1 year. And when we look at just how much disruption that has gone on and how much problems we've suffered and communities have suffered in countries because of COVID-19, it's shocking. I mean, one would think that this is a disease that has been around for very long, but it's hardly a year actually. I mean, if you looked at our countries, for example, strictly speaking, East Africa, the first cases we got were towards the end of March. So that means it's not even a year. We haven't even celebrated the first arrival day. I want to call it birthday, but the first arrival day of COVID in our region. Of course, there are those who've told us that, no, I think I suffered something like COVID a little earlier than it showed up. That could well be true. But epidemiologically, our first cases were in March. And this is a disease that began in China, a little in the late 2019, where they got an infection, a pneumonia that could just not be described. People are wondering what's causing this. Appear to be affecting mainly elderly people over 58 years of age. 58 was the median age of the earliest papers published in the New England Journal of Medicine, and that seemed to be sparing children. People with the comorbidity seem to be the ones that died most of it. And now since then, we've come to know that the disease is caused by a type of coronavirus, SARS-CoV-2, which the scientists in China were able to culture and grow it and describe its genome. And now many other institutions worldwide are able to grow that virus. And it's important they grow it because then they have to, that's when they use what they've grown, what they've cultured in their labs to do further research in two major areas. One, in terms of developing drugs, but secondly, in terms of developing mechanisms for preventing further spread of it. One of those major mechanisms, apart from epidemiological description of natural histories, is development of vaccines. And as we know, since the days of Louis Pasteur and Jenner, vaccines have evolved to become a very central and important part of dealing with infectious diseases. I, for one, know that while I really advocate and support vaccine uptake, I strongly believe that the biggest solution to COVID will not even be the vaccine. I think the biggest solution to COVID, and I've always said this to the many times I get to talk about these vaccines, will be if we can get better ways to do testing. If we can get an easier, better, rapid, reliable antigenic test, I think we'll be able to break the backbone of COVID. And the reason is because that is what we saw with HIV. The introduction of determine and CPAK as testings for HIV, which you can do in your office, wherever you are, 5 minutes, you have the result. That was a game changer. If we can be able to do that then and get a reliable one for COVID, that would be really nice, because then we can open up economies and people can travel. But while we do that, we'll need vaccines, because vaccines have been shown to be very helpful in terms of halting transmissions of many diseases. And you know, just look at the success with polio, with measles, with neonatal tetanus. And now, as soon as COVID disease came up, about 20 years, scientists had been working on different ways of making vaccines faster. And one of those ways was to see if we can use DNA and mRNAs to try and speed up the time taken to develop a vaccine and the time taken to make several copies of the vaccine if we actually indeed found that the vaccine is effective. And so since then, since February last year up to now, there have been many vaccines that have been attempted. And as you know very well that before the vaccines are tested in humans, they begin with animals. So you have the animal studies, and then after that, you come to what you call the clinical phase. So the preclinical phase is only in animals. About 89 vaccines candidates are in that process. And then we have about 64 vaccines, which are now in what we call the clinical phase. And in this phase, 64, like we are under 84, 64 are in what we call phase 1 and 2, and 20 are in the final stages. 6 have received some degree of authorizations in different countries, and 4 have received full approval for use. And then we have about 4 which were abandoned. You need to remember that it's very expensive to make a vaccine. And of all vaccines that are ever tested, maybe only about 1 or 2% ever make it to the market. The development process, of course, as you know, and as you may remember, as I've said, the preclinical phase generally takes testing this vaccine product that you have in mice and monkeys to see 2 things. 1, will it kill them or not? So is it safe? And 2, will it produce some immune response of some kind? If you did that and you are happy, then now you seek permission to start testing it in humans. So you come and get a small number of people, not so many, maybe about 15, about 10. You test it in them. And again, the thing you're testing is that does it stimulate the immune system and is it safe? And if you are happy with that, that is called phase 1, done. And then you go to phase 2. And phase 2, you get a few more people. So, okay, fine, we did 15, we're quite happy. Why don't we try 100, 200? We could even decide, let's separate, say these are children, these are elderly, these are what, and then you have those subgroups and just see how does it work out. Again, most importantly, you want to ask, is it safe? And does it stimulate the immune system? So can you be able to measure the correlates of protection? Sometimes, like for COVID, these 2 phases are combined. Phase 1 and phase 2 are combined and done together so that you have phase 1, 2, all done. We needed a vaccine very fast to be able to open up economies. Once you do phase 2 and you're happy, you say, okay, fine, we did 100 people, we got some good results. We're quite pleased. The 3rd phase is the bigger one. And this is the more important one. It's called phase 3. And this is usually where you divide the subjects that you're using for your study into 2 major groups. One group will receive the vaccine, and another group will receive something we call a placebo. This placebo could be anything. You could even use water for injection, for example. But in this particular phase, the people who are injecting the vaccine do not know which one is the vaccine, which one is the placebo. They just receive boxes with labeled with study numbers only. And then the patient who is receiving it also has no idea whether they're receiving the vaccine or they're receiving the placebo. That is called blinding. And the blinding is at 2 phases. The person injecting doesn't know, and the person receiving doesn't know. So it's called double blind. You're blinding the 2 stages. Now, this is a very important set. You must do so many people. Pfizer, for their COVID vaccine, did around 46,000, 43 to 46,000. Moderna did about 30,000. So you need a lot of people. And once you test that, then you'll receive approval. And approval comes in 2 phases. You could receive early, which is fairly limited, or you could receive early approval or limited, or you could receive emergency, or they decide based on what results you've presented. And then from there, you're able to run the administration of the vaccine as you test more. We've had a challenge, of course, with China and Russia, who started their vaccines even without going through that phase of approval. And that poses challenges because there are risks. The approval is you have to go to the regulation. FDA is the one that approves the vaccines, but even if it does, local countries have their own drug administration authorities that have to look at this vaccine. So it doesn't matter whether they approved it in the US, we still have to get it approved in Kenya. The Ugandans want it still have to be approved in Uganda. Okay, for the Tanzania, it's a bit different. They've taken a more traditional approach to COVID, so theirs is different. There are combined phases where you can accelerate vaccine development by combining phases, and I did mention that. I said you can combine phase 1 and 2, and then pausing is where the study is stopped for some time for all sorts of reasons. You know, remember the Solidarity trial for drugs, where the hydroxychloroquine arm had to be stopped when some people said they had gotten a lot of harmful side effects, and so it stopped for a while. They investigated, they were quite happy with the results. They realized that they could not demonstrate a causal relationship between the hydroxychloroquine and what they were observing, and so they allowed the study to go on. Other situations where a study is paused, by the way, could be, remember this big trial, the FEAST trial, this trial that sought to look at whether in fact you can give fluids for very sick children and see if they can help them. But the study showed that a lot of fluids, the severely ill kids were associated with higher mortality. And so the study was halted even before it was completed. So for ethical reasons, if you find that many people are being affected, many are dying, or whatever is happening that is very advanced, a study can be halted right in the middle. But it's also been done on the other side. Flipping the coin is the other way is also true. If the study is found to be so beneficial, assume you are testing something and you're finding that most of the people who are receiving the trial drug or vaccine are receiving very, very good outcomes. That particular study, where there's a huge demonstrable difference, very common with drugs, if that happens, they stop the study and that becomes the standard of care. Or on the flip side, if the people who are not getting it are dying, so your control arm, if you find that you're having so many people dying, yet the ones who are receiving whatever you are testing are surviving, then ethically, you cannot continue to let the other people die when you knew you could give them a solution that this other arm is getting. So those studies are halted at that point. But studies always have a monitoring arm that monitors trials to make those kind of decisions. They look at the statistical significance, they look at the odds ratios, the p-values and the relative risks, and they decide that I think it makes a lot of sense to stop this study here and make this the standard of care. And so the FDA made guidelines, said, okay, fine, you want to make your coronavirus, fine, you go ahead and make it, but you will have to satisfy some 3 important criteria. If you do satisfy them, then you can approach us and seek approval. The first one is that you have to show that your vaccine is at least 50% effective. Effectiveness is different from efficacy, and there is no such thing as efficiency. These are not cars, they're not German cars we are testing, the vaccine. So you are looking at effectiveness and efficacy. I had someone on the TV the other day talk about the vaccine being 95% efficient. It's not efficiency, it's effectiveness. Efficacy, where you are testing the vaccine in controlled surroundings, in a trial, and you are controlling everything, and you're happy with whatever comes out, that's efficacy. When you pick it from that and take it into the normal environment of day-to-day living, and the vaccine produces results, that's effectiveness. This vaccine should be at least 50% effective. The first time I saw this, I thought it was quite low, but then I remembered that flu vaccine is only about 40 to 60%. So I think FDA didn't want to be too, but the companies have shocked the FDA and come up with very high percents, 95% for Pfizer and Moderna, vaccines, the mRNA vaccines. So it's a good thing. Second thing, vaccine makers must follow the volunteers for a median of 2 months after the final dose. So you give the dose, after 3 to 4 or 4 weeks, depending on the vaccine, you give another one. Then from there, you'll have to follow them up for 2 months to be sure that it does not cause dangerous harm. And then you have to document at least 5 cases of severe COVID-19 observed in participants who have received a placebo. Why is this important? This is important because you are not going to tell us that the vaccine is working if actually we are not so sure that the disease is actually present in the population. So some people in that population should suffer the disease and suffer it so severely that we are sure that, and that's what FDA wants to go. No, document 5 in the population, then they know that, okay, fine. And so you are picking the ones who got the placebo must get the disease because they do not have the protection. So those are the 3 criteria for them to seek approval. So which kind of vaccines are RNA vaccines? This is a totally new technology where you inject mRNA into cells, they produce the required viral proteins directly inside the human body. So many times we've done it differently. Previously, either we attenuate the viruses or do what, but this one, we get the message about the coronavirus and give the message to the cells and let the cells respond to that. And a big advantage of this is that scientists can be able to skip lab production of proteins because you directly inject the molecular instructions to make the protein into the human body itself. As you are aware, the mRNA is outside the nucleus. So these people who go around saying that, oh, these vaccines are going to affect our DNA, they are going to harm, there is no way, because unless if you don't know or remember your cell biology, It's not in the DNA, so it cannot alter the DNA. And so the sequence is taken from the virus genome, the SARS-CoV-2, and then it's used to stimulate the production of antibodies. And this is what Moderna, BioNTech, combining with Pfizer, and then CureVac from Germany and Belgium are using this. So this becomes cheaper, faster to produce, and you can easily scale it at a high rate. Adenoviruses have been used when they are genetically engineered to express viral antigens found in SARS-CoV. Usually the spike protein, which we know that is the most considered one. And when put into a vaccine, adenoviruses trigger an immune response in the human body, protecting against COVID-19. We know examples are like a Chinese company, the CanSino Biologics, which is making the adenovirus vaccine. We also know that Janssen, which is a subsidiary of Johnson & Johnson. And then Oxford University, which has partnered with AstraZeneca to make their vaccine. You could also use inactivated pathogen, and most traditional approach is this, where you have a pathogen that stimulates the immune system to produce antibodies. Already we have a lot of vaccines that are like this. They could even be killed, they could even be weakened, and you do know a lot of these vaccines that are used in routine immunization programs. There is a company called Sinovac from China, which has tried this method for their vaccine called PICOVAC. And there was even a team in Australia that was trying to look at the BCG vaccine and see if it could actually be used to protect against COVID. The results were not so promising. There's of course always a challenge with this kind of approach, because when you have to grow a lot of viruses in the lab, which then you can use. But growing so many viruses, it's quite challenging, especially if you're dealing with a global pandemic, because it's not easy to scale it up. The DNA vaccine, on the other hand, involves injecting fragments of circular DNA that you know we call them plasmids into human cells. And so it will introduce the codes for coronavirus proteins. And then these ones will be expressed by cells and can always help to prime the immune system to fight off an attack. And equally a new technology, this one. And Inovio is the company that has the leading candidate to also try to produce a virus, the same technology against MERS virus. There are several other teams also working on DNA candidates for this vaccine at the Harvard Medical School. And then finally, we have the viral proteins. These are genes that code for proteins from pathogens. Like in the case of COVID, we use the spike protein. Sanofi Pasteur tried this, because remember they had earlier tried to do a vaccine for SARS. So all they did was to try and repurpose it. There was even a team at the University of Pittsburgh, where they were also initially were already working on SARS and MERS vaccines, but they quickly tried to repurpose that for the spike protein. Novavax is another one that has developed a way to package their spike proteins. And also Medicago from Canada is another country that is producing virus-like particles of the coronavirus that are expressed in the leaves of Nicotiana bethamyania. This is a wild relative of tobacco. So having gone through all that science and biology, we can now talk about the vaccines themselves. And the question is, so where are we with these candidates? So the four that I talked about, there is AstraZeneca. This particular vaccine is about 62 to 90% effective. And the beauty about it is that it can be stored at routine fridge temperatures of 2 to 8. And then the doses are 2. Same to Sputnik V, the viral vector vaccine for Gamaleya. And again, I remember I told you these two vaccines use adenovirus that is modified. It's 92% effective. It can be kept at regular fridge temperature. And then we do have these other two RNA vaccines, Moderna and Pfizer. 95% effective, very, very high effectiveness. negative 20 degrees for Moderna for up to 6 months, and negative 70 for Pfizer. This negative 70 of Pfizer can be a bit of a challenge, for areas where you don't have a lot of good cold chain capabilities. But I don't think it's a barrier in itself. Countries can overcome that, because the Ebola vaccine that we used in the Congo recently was negative 80. So when the countries are interested, they can do it. The Pfizer-BioNTech vaccine is injected in the muscle 3 weeks apart. 3 weeks. That's how it differs from the Moderna one. And you can see the countries on that map which already have given it either early or limited approval or full approval, as you can see. As for the Moderna vaccine, you can see it's 4 weeks apart. So Pfizer is 3 weeks apart, Moderna is 4 weeks apart. Again, an injection, 30 days, you can keep it with the refrigeration, 6 months at -4 Fahrenheit, which is at -20 degrees Celsius. Again, you can see the countries that have embraced the Moderna vaccine. The Moderna vaccine is more expensive than the Pfizer vaccine. Moderna is close to almost 50 euros, but the Pfizer vaccine is about 30. The AstraZeneca vaccine is the cheapest, around 3 to 5 euros. So how do Moderna's early results compare with Pfizer's? While we know that these two vaccines satisfied the FDA's requirement, Moderna may be preferred because of its favorable fridge and cold chain requirements of -20. But that is if you are comparing the two RNAs. Otherwise, if you compare with the third ones, then the Sputnik and the AstraZeneca vaccines have more favorable cold chain capabilities. The fact that you can store them at normal fridge temperatures of 2 to 8. And that's the AstraZeneca one. So 62% to 90% depending on dosage, again, 2 weeks apart. So you can see they are 2 weeks apart, 4 weeks apart. So these two are also 4 weeks apart. So it's only one which is 3 weeks apart. This is the vaccine that is going to be used on a larger scale in Africa. And I just mentioned that a little late in the slides. So on the 23rd of November, AstraZeneca and Oxford announced that their vaccine made by genetically engineering the adenovirus that normally infects chimpanzees had good efficacy. And based on a study in the first 131 cases of COVID-19 in trials in the United Kingdom and Brazil. And volunteers all got 2 doses, but in some cases, the first dose was only half strength. And surprisingly, an initial half strength dose led to 90% efficacy, while 2 standard doses shots led to 62% efficacy. The researchers speculated that the lower first dose did a better job of mimicking the experience of an infection, promoting a stronger immune response. But only after the initial announcement did it become clear that the low dose version was the result of a mistake in how the vaccines were measured out, not part of the original plan for the trial. So it was a mistake within the trial. And it also emerged that the low dose was only tried out on volunteers under 55 years of age. And this raised more questions about how strong the preliminary results were. But despite all these issues, the United Kingdom and Argentina gave the vaccine emergency authorization on the 30th of December, and on 3rd of January, India followed suit, approving a version they call Covishield, made by the Serum Institute of India. So where are we up to today? The information I have is as up to 10th of February, where a vaccine from Italy's Turkey's and Rotterdam entered phase 1. South Korea's Bioscience moves to phase 1 and 2 by February 8. South Africans halted their plan of rollout for AstraZeneca vaccine. And this is because they found that in some cases it was only about 10%, about 15% effectiveness. It's thought maybe it could be related to the strain that they are having now, the mutation in the virus. A second vaccine from Iran entered phase 1 this month of February. China gave conditional approval to Sinovac vaccine this same month. New York-based COVAX moved into phase 2 with their study this same month. Vaxxed stock plunged after they reported low antibody response. Okay, that's for businessmen. And Mexico authorized the Russia's Sputnik V vaccine. This same month, Russia's vaccine was reported to have an efficacy of 91.6% this same month. And Cubans have their own Abdala vaccine that moved into phase 2. Hungary was the first EU country to authorize Sinopharm's vaccine, and the EU authorized Oxford AstraZeneca vaccine in January 2019, 29th, and 29th of January 2021. And this was such an important thing because now the entire European Union were authorized to use AstraZeneca vaccine, despite the challenges that it was having in the study. So that was quite good. And in any case, anyway, their 62% is still way above the 50% that FDA has. So it's just that we have gotten a bit gullible, having gotten a 95% with Pfizer. And so people look at AstraZeneca with kind of tinted glasses. Johnson & Johnson, remember they're also doing an adenovirus vaccine. They reported low efficacy data in South Africa. Same for Novavax, also reported lower efficacy in South Africa. So quite a number of them have reported poor data in South Africa. Could it be because of the mutations? So those are the leading vaccines: the Pfizer one, the Moderna, the Gamaleya one, that is Sputnik, the Oxford AstraZeneca, Casino, Johnson, the Vector Institute, Novavax, Sinopharm, Sinovac, Sinopharm one, and Bharat Biotech. Bharat Biotech is a big company in India. I had the opportunity to visit their plant in Hyderabad. So again, if you look at the countries that have got the vaccine, you can see there total reported vaccine doses administered per 100 people. And again, you just see those countries. But the question is, Africa, you can see there's no data. The first country to ever give vaccines in Africa was Guinea. Gave it about 20 people. That's in the poorer countries. Seychelles has requested for vaccines to literally cover the whole country and introduce it into their program. So Africa is still kind of like in a disconnect. And so the question is, where is Africa headed? So there's a coalition called COVAX. This is the vaccines pillar of the Access for COVID-19 Tools Accelerator for Global Equitable Access to COVID-19 vaccines. This is targeting 92 low and middle income countries. So not all African countries, just all poor countries. And what they've done is that COVAX is, of course, established by the alliance between the Coalition of Epidemic Preparedness Innovations and Gavi Alliance and WHO. It just wants to bring together countries, check how ready they are for the vaccine and supply them. So it's ordered about 600 million, but COVAX will only supply 20% of populations in African countries. Only 20% of the populations. So they want to make sure that at least they give the vaccines as soon as possible, because the goal of COVAX is to end the acute phase of the pandemic, at least enough to allow economies to begin to rebuild. So they've entered into agreements with AstraZeneca for 170 million doses. And then they've signed an MOU with Johnson & Johnson for 500 million doses of their Janssen candidate. And then they have other agreement with the Serum Institute of India. And Serum Institute of India is producing the AstraZeneca vaccine. I already told you earlier about it, Covishield, and then Novavax. So phase 1, COVAX countries initially receive vaccinations for 20% of populations, enough to immunize target groups. Healthcare workers will be the given preferential considerations, and then older adults, and then those who have serious comorbidities. And then the phase 2, the pace of sending doses is prioritized by country risk. Countries under risk of high impact of COVID, so you're looking at like South Africa, for example, and then countries with vulnerable healthcare systems, and then countries with vulnerable populations. So that is how the phase 2 will be. And in addition to phase 1 and 2, some doses of vaccine will be reserved for other vulnerable populations. This may include refugees, This may include those seeking asylum and workers who work with these groups. So we need COVAX because developing a vaccine against COVID-19 is the most pressing challenge of our time. And nobody wins until the race. Nobody wins the race until everyone wins. And so the global pandemic, as we know, has already caused a lot of losses. So we do need this COVAX. And African countries are poor. They won't be able to negotiate on their own. Negotiating as a team is better. In fact, over and above COVAX, the African Union has started its own initiative. African Union Vaccine Acquisition Task Force has secured 270 million doses of COVID-19 vaccines for African nations only. This, unlike COVAX, which looks at all low and poor countries, this one is only focusing on African nations only. So the vaccines will be supplied by Pfizer and by Johnson & Johnson, as well as AstraZeneca, through an independent license with the Serum Institute of India. And the batch is strictly for purchase by African nations. And the purchases will be made through the Africa Medical Supplies Platform and the Africa Export-Import Bank, which will help the countries to secure at least some financing to help them purchase the vaccines. So when the vaccines are delivered, the countries could either pay for them directly from their resources or get a grant or kind of a loan, a 5-year installment payment plan through the bank. So these countries that you see from the African arrangement will also receive vaccines from COVAX. Kenya and Uganda are getting vaccines from both arrangements, or at least planning to. The only challenge is that even if they did and these organizations worked, still we won't be able to reach a critical percent that we desired, like 60%, before we can begin to talk about the possibility of herd immunity. Egypt, Morocco, and Seychelles, like I said, have procured the Sinopharm vaccine from China, while Guinea procured Russia's Sputnik 5 vaccine. I remember I told you Guinea was the first with about 20 people vaccinated. The first doses of vaccines from COVAX facility are expected to arrive around March, so that's next month, and with a larger rollout expected in June. I know that Kenya, we are going to roll out a little sooner, and tomorrow we'll be having that conversation in the evening. You should be able to log in and follow that KMA organized CME. We'll be discussing the rollout of vaccine in Kenya in a huge panel. You must have seen the poster circulating already. So we hope that at least by end of 2021, Africa should have covered a significant part of their high-risk populations with this. So countries can take from COVAX or can take from both COVAX and the AU arrangement. I think that they should target to get from both. And then their own local NDS can evaluate the vaccines, and they should be able to roll them out. In the meantime, of course, there are issues which countries should be addressing. Issues of hesitancy, particularly among healthcare workers, vaccine refusal, stigma, and mental health and long-term effects of COVID, which we are seeing to be quite common also in recovering patients. There is some degree of immunity that we know after the first dose of COVID-19 vaccine, but it's not optimal. And we don't know actually how long it will last. So it's important that people get the vaccine, get the 2 doses. Second dose helps you to have your immunity lasting considerably longer. Already a bridging study has been launched in children that will probably begin, that began last month, rather, this is an old slide, but it's to make sure that COVID-19 efficacy and safety data in children is documented, and then you compared to adults. Of course, the kids can be going to school in the meantime. We hope that come around between April and June, that should give us an open season for the general public to start receiving COVID-19 vaccines. It may be quite ambitious for Africa. Maybe I should have said August, because our countries are a bit slow. But as long as the current rollout to priority groups goes smoothly, that then should be able to be considered. People who are hesitant to get COVID-19 vaccine should be assured that the approval process has been independent and transparent, and it's made by people who have no allegiance to the governments or the companies that were making them, so that people can build their confidence in this vaccine. Because the other thing you need to remember is that, and this is an important point, you know, generally about RNA vaccines, they love to mutate. They really love to mutate. So like all RNA viruses, this coronavirus has been mutating. Yesterday, I just heard that America has 7 new strains which they're testing, 7, which are indigenous to the US. Add to that the Brazil one, add to them the South African one. So you realize that and the UK one, we are facing quite a bigger challenge. So with all these variants that are showing up, we need to continue all the containment measures, even if we get the vaccine. So allow me to stop there. Thank you so much for listening to me.
Thank you very much, Dr. Ombeva, for that very elaborate presentation on vaccines. You take me back to the classes of the CAVI, but now with addition of the COVID vaccine. And we hope that these lessons go deep to all our attendees. Though we have a number of questions for you, Dr. Ombeva, and one very key question which has come up, what happens to the COVID survivors who had the infection and have recovered? Will they still need the vaccine, and will there be any issues once they do get the vaccine? So over to you, Dr. Ombeva.
That's a very good question. Traditionally, we have always known that infection for some conditions tends to confer immunity. But studies are beginning to show that infection with the COVID may not give you as strong an immunity as the vaccines, particularly with the new technology that we are using to get the vaccine. So all the CDC recommends that all those who suffered COVID must get the vaccine. There are a few people who think that they suffered COVID, who got it a bit early before testing was very good. And they think that they had COVID. It may not even have been COVID. So when the vaccine comes, people who have suffered COVID and recovered, like myself, will have to be number 1 on the line to get the vaccine.
Thank you very much, Dr. Ombeva. A few more questions on the chat box. Who's eligible? And let me look at that question again. Who's eligible?
The COVAX and the African Union vaccine arrangement, like I said, preferentially, the first people who will get it, and countries have to commit, will start with healthcare workers. After healthcare workers are done, then they will go to those first responders, the people who are likely to come into contact with high cases of COVID. So they'll have to be considered. So here we are looking at firefighters, security people, all those who are likely to, Then we have the elderly, and then people with comorbidities. Only when we are done with those shall we move to the general population.
Thank you very much, Dr. Ombeva.
Incidentally, actually, I've looked at the scoring, and the elderly will be able to get it before those with comorbidity. So if you are young with a comorbidity, the elderly will go ahead of you.
That's fantastic, because we really need to take care of the older persons. There is a question here. How many doses does one get, and after what period for the vaccines that we are getting? And how,
like I've said,
any long-term side effects?
And how long
are there any long-term side effects from the vaccines that we expect?
Okay, so those are good questions, very good questions. The first one is that the vaccines are either 3 or 4 weeks. And you saw from my presentation, majority of those, like the ones we get here are 4 weeks apart. So that's it. And then the question of side effects, most of them are mild. A bit of pain at the injection site, some may be a bit of swelling, and a bit of malaise just for that day. But after that, we do not know of any other serious or severe side effects yet.
Thank you very much. There's a question here which I think even will really be answered on Friday in terms of in our country, Kenya, which hospitals will offer this particular vaccine. And I think this is the vision of KMA to try and see how public and private partnerships will be embedded. So I would ask that candidate to ask this question, to shelf that question for the Ministry of Health on Friday. Do log in and register. So, Kizito Labano, thank you very much for being logged in today. And this is his question. What's the projected impact of the variants on the existing vaccines?
So first of all, the question about private sector involvement, we will answer it tomorrow when we have the open session with the ministry and KMA and academia tomorrow, where we'll go into greater details. But the most important thing is that you need to know that every healthcare worker, whether you're in a private setting or government setting, you will be priority for the vaccine. Projected impact of variants on the existing vaccines, it's a big, big worry. For a time, we thought that we may have an opportunity for the mRNA vaccines, at least to confer a bit of stability in terms of the new variants. But just yesterday, Pfizer said that there's a big worry that their vaccine may not perform as well, even with the variants that are coming up. So it's something that is being checked yet. The only promising thing about the new variants is that early indicators have shown that while they are easily spread, while they are very infectious, they have not been shown to be associated with increased chances of death. So they are not more virulent, while they are more infectious. But I know that we know that more studies are going on, so we'll see how this evolves. It's early days. In terms of whether we have those variants in Kenya, not yet, but active lookout and typing for them is going on to try and characterize the serotypes of the viruses that we are seeing in our population across East Africa, I think. And I think every country has become very vigilant in looking through the samples just to see that whether we have any variants. Like I said, it is a sad thing because the US has reported 7 new variants. But remember, RNA viruses, that is their biggest behavior. They love mutating. So that is the thing. Moderna said that they think their vaccine is stable, more stable with the variant. But there's been conversations in the vaccinology circles whether in fact a 3rd dose may help to deal with those variants. So it could be that people may need to get a 3rd dose of the vaccine a year after the 2nd dose.
Thank you very much, Dr. Malande. Very elaborate. So one more question from Dr. Duor before we wind up is there's a query that yes, we are having 2 vaccines coming into the country, 2 different ones. And we've seen even various countries using different vaccines at the same time. What's the importance of this? And why are they combining vaccines rather than going with one vaccine? Is there any significance of combining?
So the point is that we actually do not know. We actually do not know whether, in fact, let me even set one question and answer for myself. One of the questions people have asked me is that if I got the 1st dose of one vaccine and I get the 2nd dose of a different vaccine, can I finish my schedule like that? And the point is that we actually do not know the accurate answer to that question yet. We, as much as possible, encourage that if you got a Pfizer vaccine, get a Pfizer vaccine for your 2nd dose, or at least get vaccines with the same mechanism. So Pfizer and Moderna are all mRNA, but AstraZeneca and the Sputnik vaccine are adenovirus modified. Now, AstraZeneca has actually entered an agreement with Sputnik to try and see if they can combine their vaccines, hoping that that will help improve the efficacy of the AstraZeneca. Remember, we talked about 62%. about 90%, and that 62% was people who got 2 doses. So they are hoping that maybe by combining the two, they may raise it up to somewhere maybe close to 80, 90. That again, yet is not known. So the decisions made into how much or which vaccines come into the country, it's strictly to do with availability. It's just, are they available or not? Because that's a problem. People have the money, they want to get their vaccines, but there is no vaccine out there. Even the US, there's a lot of scramble for the vaccine. So it's a big challenge. I know that there are several different vaccines under the African Union facility. Kenya may end up getting AstraZeneca through COVAX, and then when it comes to the African Union, if we do not have enough AstraZeneca vaccine available, we may end up going for a different one. But what I know is that a lot of those questions will be answered tomorrow in the open panel.
Thank you very much, Dr. Ombeva, and it's a privilege to have you on today, and we look forward to tomorrow's presentation because it will highlight a lot. Those who have asked questions which haven't been answered here, they'll be answered tomorrow. We'll share with the speakers for tomorrow, and they'll also be able to highlight them. So I hand over back to Dr. Kigondu. I am Dr. Mugambi, and I look forward to tomorrow's event. Thank you. Dr. Kigondu, over to you.
He's muted.
Thank you very much, Dr. Joy Mugambi, for excellent co-hosting. Thank you, Ombeva, for the unmute. With us today, we have Dr. Otara, who is the Vice President of Kenya Medical Association in the panel. We also have Nyandika from the National Nurses Association. As you know, these webinars are usually joined with NNAK, KCOA, KMPDU, and KMA. And Nyandika, you want to say something?
Thank you, Daktari. I don't really have much to say, just to thank Dr. Ombeva for the good presentation. And I believe that the uptake for the priority groups will really determine the public uptake of the vaccine. And Dr. Ombeva has really done a good job in trying to reassure the health community on the effectiveness of the vaccine. So I'm really grateful to be here today, and I thank the panelists for the good job. Thank you.
Thank you very much, Nyandika. And as Dr. Ombeva has alluded to, tomorrow at 7 p.m., we are now hosting the Ministry of Health, and we want to hear what their plans are for bringing the vaccine. What are the steps that they have taken? And in that, it will be a very high-powered level. Therefore, keep on the lookout for the link, which will be shared on all social media platforms and tomorrow. And I think Dr. Ombeva, you'll be there. Yes. And with that, I think I want to bring this session to a close. I'm sure all the questions that have been looming or about the COVID vaccine, a lot of them have been answered. And for those that have not been answered, I think there's another opportunity tomorrow at 7 p.m. So for now, for your CPD points will be sent to your email if you are for the doctors and nurses. I had a question about PharmTex. I think the PharmTex need to contact Peter. Peter is a KMA ICT officer in charge of the CPD points, and we'll give you his contacts soon. And with that, I want to bring this session to a close and wish all of you a good day. And we will continue with our COVID webinars next week on Tuesday, the psychological ones, and on Thursday, 2 to 3, the COVID case management series. Thank you very much.
Thank you. Bye.
Bye. Bye.